And it is now my pleasure to introduce Professor Young Baek, who's coming to us from Asan Medical Center in Seoul, South Korea. We all know Professor Baek as a pioneer in the field of radiofrequency ablation. And he will present to us his assessment of thyroid radiofrequency ablation of malignant tumors. Professor Baek.
Thank you, Chairperson. Good afternoon, ladies and gentlemen. Today, I'd like to talk about RF ablation for recurrent and primary thyroid cancers. Our society released 3 times our opinion, and in 2012 guideline, we recommend RF ablation for recurrent cancers in limited patients. Last year, we revised our guideline, and the guideline suggests RF ablation for primary and recurrent cancers, also in inoperable patient only. The guideline suggests 2 strategies. One is cure, and the other is palliation. Cure means we treat any visible cancers on ultrasound, and we usually combine radiofrequency and the radioactive iodine therapy. In palliative setting, we treat patients with cosmetic or symptomatic problems, and we treat tumor near critical structures such as the trachea, skin, nerve, and vessels. And we frequently combine RF ablation with radiation therapy and or TKI. This is the protocol in Assam Medical Center. As you know, TKI, we use sorafenib or lenvatinib and destroy the tumor vessels and induce tumor necrosis. This study shows publications of RF ablation for recurrent cancers. Most of studies tried the cure, but one tried palliative ablation. And this table shows clinical outcomes of studies tried cure. As you can see, volume reduction is very excellent. Usually more than 90% of volume reduction. What about the complete disappearance? 50% and 82% in our study. Yellow colors are our studies. And the serum thyroglobulin decreased in majority of the patient after ablation. But the thing is, number of patients are usually very small, and the follow period is usually around 2 years. Let me show representative case of a cure. This young female patient received total thyroidectomy, and we found single recurrent lymph node at left level 3. You can see the carotid artery, jugular vein, and recurrent tumor here. During ablation, we can see the wide ablation zone, including the tumor and surrounding soft tissue, to prevent marginal recurrence. What about the 1 month? Tumor decreased considerably. 3 months, it is nearly disappeared. It is tiny hypoechoic area. We performed combination therapy for this patient. RF ablation treated the visible tumor on ultrasound, and the radioactive iodine therapy treated the possible invisible residual tumor, and thyroid hormone therapy suppressed the tumor recurrence. So now, 8-year follow-up shows no tumor recurrence. This is the typical case of cure. Let's move on to the palliative setting. When you compare the cure and palliative treatment, what about the volume reduction and complete disappearance? It is much higher in cure setting, but palliative treatment, stress, symptom improvement in 64% of patients because they treated only inoperable symptomatic recurrent thyroid cancers. Our center recently published this article. This article evaluated the causes of death in recurrent patients. What is the most common cause of death? Airway problem, especially in elderly patients. Let me show this case. This patient was confirmed follicular carcinoma at surgery. First surgery was done in 2004. 4 years later, we can see the huge recurrent tumor involving trachea and esophagus, this area. Performed the second surgery. 2 years later, also we can see the recurrent tumor involving trachea and esophagus. At the time, we performed 2 times of RF ablation, followed by radiation therapy. This area, treated by RF ablation, this area was managed by radiation therapy. 1.5 years, the tumor decreased more, 2.5 more decreased. Enhancing area is much decreased, this area here, and 4-year follow-up, the patient is stable. So combination of RF ablation and radiation therapy is very effective in patients with airway involving tumors. What about this patient? This patient received total thyroidectomy and the recurrent tumor inside the trachea here. You can see the enhancing tumor. 2 years later, the tumor progression inside the trachea and the outside trachea involving strap muscle. This coronary imaging shows a tumor inside the trachea. At that time, the patient complained of a hemoptysis. Our multidisciplinary team discussed about this issue, and we decided stent-assisted RF ablation. Here is the concept of a stent-assisted RF ablation. Tumor involving trachea and grow inside. The patient complained of 2 symptoms. One is hemoptysis, the other is dyspnea. So we immediately apply the tracheal stent like this. Tracheal stent maintains the airway and push the tumor outside the trachea. Initially, you can see the enhancing hypervascular tumor. Tracheogram shows irregularity of tracheal wall. After stent application, this ultrasound image, you can see the echogenic tracheal stent here, and the tumor pushed out by trachea here, and you can see the feeding artery to tumor here. So I ablated not only the tumor, but also feeding artery together by single session RF ablation. Next day, I found tumor vascularity is completely disappeared. 10 days later, here you can see the stent. 10 days later, we removed the stent. The patient was stable, and we did not combine the radiation therapy because I have confidence. I treated the majority of the tumors completely with the feeding artery. CT scan before 4 months, there was no enhancing lesion. What about the 10 and 16 months? No tumor at that time. And recently, we followed 28 months follow-up CT scan. I found a small amount enhancing area here and here, and the lung metastasis was enlarged. Initially, there was a small multiple lung metastasis. However, patient was stable, no symptom. What about the PET-CT? PET uptake area is completely disappeared. So I explained the two strategies, cure and palliative treatment. Let's move on to the primary cancer. The guideline suggests RF ablation for inoperable primary cancer patient. This table shows a summary of somal ablations, microwave, RF, and laser ablations for PTMCs. Local tumor recurrence, no. Distant metastasis, no. But one study shows lymph node metastasis. Complication rate was acceptable. So all studies shows a very excellent result. But the thing is, follow-up period, very short. So our center performed 4-year follow-up study. Although number of patients were only 6 patients. Among 6, 4 disappeared completely. 1 remained, 1 decreased markedly. 1 remained as a calcified tumor. 4 patients showed a completely disappeared tumor. 1 remained like this, scar-like lesion. We performed core needle biopsy. There was no tumor. This patient shows hypoechoic cancer with central calcifications. 3-year follow-up shows hypoechoic area is completely disappeared, but calcification was remained like this. I explained the pattern of thyroid tumors after radiofrequency ablation. This is the recent Korean study, RF ablation for low-risk PTMC in a large population. This study treated 152 PTMCs. Mean follow-up period was around 40 months. Mean treatment session was 1.1. The result shows no local tumor recurrence, no cervical lymph node metastasis, no distant metastasis. But during the follow-up period, we found 4 new PTMCs in 3 patients. However, these PTMCs were managed by RF ablation, and all disappeared completely. What about the multiple cancers? This study treated multiple PTMCs. No other study treated multiple cancers, only single PTMCs. They reported like this. Similar result to those of single PTMCs. In summary, reported cases shows excellent local tumor control and no clinical recurrence during 4-year follow-up, except 1 lymph node metastasis. However, Dr. Barkabi reported different opinion. They treated 3 PTMCs by laser ablation and performed surgery. The surgical result was evaluated the previous speaker. The result shows laser ablation achieved excellent local tumor ablation. Ablated tumor was disappeared. However, tiny satellite cancers and microscopic lymph node metastasis, that is problem in this case. And this is a limitation of local tumor control method. What about the anaplastic cancer? Anybody treated anaplastic cancer experience? Nobody? This study evaluate the result of RF ablation according to the pathologic types of cancers. We divided the 3 types: microcancer, macrocancer, both without lymph node metastasis, and anaplastic cancer. As we know, microcancer achieved excellent result. After ablation, disappeared completely at 1 year and stable at 4-year follow. What about this one? This 83-year female patient has macro cancer with a solid and cystic component. She complained of anterior neck discomfort and cosmetic problem like this, and she's in inoperable state. What is your first choice? Because the cystic space was very large, I aspirate the fluid, but recurrent at 1 month. Aspiration again, also recurrent. So our thyroid team decided RF ablation for this patient. I treated this tumor focusing on solid component, and then ablate the septum, and then ablate the peri-tumoral soft tissue as much as possible, and then aspirate the internal fluid like this, serosanguinous fluid, before more than 100 milliliter, 1 month. Cystic space disappeared completely, and the solid component remained like this without vascularity. 5 months, decrease gradually like this, 1.5 year, and 31 months, it decreased, and no vascularity, no distant metastasis, no lymph node metastasis at that time. Finally, anaplastic cancer invade the carotid artery like this. First, I treated this area, and then this lateral portion of the tumor. 40 days after first ablation, what do you think about this CT scan? What about the tumor size? Total entire tumor size is increased. And can you see this enhancing area inside the ablated portion? The tumor grow inside the ablated area like this. So, in summary, in recurrent cancers, I explained 2 treatment strategies, and we frequently use combination therapy based on the decision making of our multidisciplinary team, and this critical structure involvement should be treated more aggressively. In primary cancers, somal ablation achieved excellent local tumor ablation. But the thing is, satellite small cancers, microscopic lymph node metastasis. And I don't recommend RF ablation for anaplastic cancer because it's a very rapid doubling time. Finally, let me introduce our next year international conference. This is our ultrasound meeting, international meeting. And among 3 days, we organize 2 days thyroid intervention program. So I hope to see you again in Korea next May. Thank you.
Thank you very much, Dr. Beck. A very interesting and forward-looking presentation. I'm sure some people will be interested in asking you some more details. Please come to the microphone.
Hello, I'm Alberto Ragni from Turin, Italy. Congratulations for your presentation. I wanted to ask the management of the association of ablation with tyrosine kinase inhibitors. For example, what's the time of when you suspend therapy with TKI before ablation?
Yeah.
Thank you.
That's very important question, but combination of RF ablation and the TKI is somewhat complex. As we know, lung metastasis is very excellent by TKI, but neck metastasis is less responsible. So during using of TKI, lung mass decrease usually, but neck mass increase. So as I introduced, increase the neck mass approach close to the airway or some critical structures, we combine RF ablation. It's our usual strategy, but somewhat complex. It's somewhat complex.
Hello, Andreina Lavarria from Madrid. In the oncologic setting, do you modify your technique in order to improve and have a security margin around the tumor? And if so, have you ever treated lymph node recurrence? And in that case, have you seen worst pain management afterward due to burn through muscle around the lymph node?
Yes, that's very good question for safety of a patient. Almost always, in terms of treating recurrent cancer, we almost always use a hydrodissection technique. Based on the ultrasound anatomy, we inject cold water, 5% dextrose water, between the tumor and critical structures. Continuous injection during the ablation. We can minimize the thermal damage to normal structures.
I would like to ask one question. It's very appealing to look at treatment of micro-PTC with RFA. And you mentioned that vast majority of patients had a single lesion, yet some, at least one study you mentioned, look at multiple lesions. In our experience, every time we see multifocality, even if lymph nodes are not noted on ultrasound, we find them at surgery. So what's your opinion about venturing to RFA, treating just what's seen on ultrasound as opposed to considering surgery?
Yes, I agree with your opinion. My explain was most of studies enrolled single PTMC on ultrasound. Therefore, they may miss the possible cancers. Let me show another slide. This is our recent publication. Meta-analysis of active surveillance. This is well known. During 5-year follow-up, the tumor progression is around 5%, and the lymph node metastasis is around 1.6% at 5-year follow-up. But the thing is, this is a problem of active surveillance. You can see the delayed surgery, number of delayed surgery, 30%, 50%, 3%. But tumor progression is less than half of this number. I mean, the another lesion is more popular. This is mostly anxiety of the patient. anxiety-induced surgery. And another study, also meta-analysis of PTMC of thermal ablation, shows how many new cancers are detected during follow-up period. New cancers is very small. As we introduced our case, this Korean case shows among 152 cancers, you can see the only 4 new cancers. That means there may be cancers, very small cancers, but growing is very rare. Clinically indolent, clinically not meaningful cancers.
Thank you. Very helpful. Any other questions? In that case, we want to thank again all the speakers, thank Dr. Beck, and this session is now closed.